So I'm going to talk about depression and apathy. These are two of the most common behavioral symptoms that occur in people with degenerative diseases. Depression happens to be one of the most common behavioral problems overall. So as a psychiatrist, we see depression very, very frequently. About 1 in 6 people, 1 in 5 to 1 in 6 people will have an episode of depression at some point during their life. So this is a lay description of what depression is. It isn't a medical description per se, but it is pretty close to what we call depression clinically. And we'll talk about the specific medical definition of depression. But a state of lowered mood, and often accompanied by disturbances of sleep, energy, appetite, concentration, interest, and sexual drive. And that's actually a fairly good summary of what we're looking for as clinicians when we're looking to see if someone has depression. As I mentioned, about 1 in 6 people will have depression at some point in their life. That's about 15%. In people with neurologic disorders, and this is pretty much across the board, traumatic brain injury, Alzheimer's disease, Parkinson's disease, the rates are around 30%. Much higher in some illnesses. So in multiple sclerosis, for example, some studies have said the rate is as high as 100% of depression at some point during the course of that illness. Even though we know that depression is very common in neurologic illness, we as neurologists don't do a really good job of recognizing it. A lot of times we will tend to attribute depression to other factors. Well, someone with Parkinson's disease is having more trouble with doing their daily activities, so of course they're sad, and we chalk it up to that. Sometimes the patients themselves are unaware because we haven't educated them well about what the symptoms of depression look like or to watch out for depression. And then in diseases where there's a memory problem, it may be difficult to even remember, what your sleep was like, what your appetite was like, and how those things might have changed in order to tell the doctor so that they can help you. We don't ask very well, so we're not very good at asking about depression. And even when we ask about depression, sometimes we do it in a way that's not very useful. Are you having any depression? Well, if an individual doesn't know what the term means, or if they have a very different idea of the term from what you have, then you're going to get an answer that's not going to be helpful in treating them. So you have to ask questions the right way. We as providers have to ask in the right way. And we have to also educate people as to what we're asking about, and also to look out for these symptoms over time. On top of that, even once we manage to, if we do, find out that someone has depression, we're not very good at treating it and getting rid of it. Part of that is the treatments themselves. There are people who, regardless of what you try, you don't get much of a response in terms of symptoms. But part of it is doctors not being as aggressive as they should be in changing medications or increasing medicines. So it's a big problem, and maybe I shouldn't say this, but in some ways we make it a bigger problem than it actually has to be. So the medical definition of depression. Depression is a persistent, I should have put persistent sad or mostly unhappy mood. So the mood can either be sad, meaning frankly someone feels sad, feels down, or it can be that they're not able to experience happiness in the way that they typically have in the past. Things may feel just a lot more dull. And it has to be the predominant mood state most of the time for at least a couple of weeks. Of course, if someone has just had a major loss or something like that, then they may have depression symptoms after that loss. But usually we expect those symptoms to get better over time. So you do want to know what the context is in which these symptoms occur. And there are other symptoms. So just having this mood state is not enough for us to diagnose depression. Have to have other symptoms. Some of those were referred to in that lay definition of depression I showed you before. So the symptoms that we characterize as part of the syndrome of depression: a change in sleep pattern, reduced interest in things that used to be interesting, feelings of guilt, either sort of looking back on life and feeling like you did things wrong, or feelings of worthlessness, so feeling like your future isn't worth much or you as a person are not worth much. Most people with depression will have a decrease in their energy. So they'll feel tired in general, or they won't be able to maintain their energy as they do activity, so they'll become fatigued very quickly. Concentration gets affected. There can be changes in appetite, either more appetite or less appetite. Sometimes people won't notice that they've changed their eating habits, but they'll change weight. Their weight will go up or down, and that can be a symptom of depression as well. People with depression can have what we call psychomotor symptoms, so changes in the way that we think and move. And it's usually the psychomotor retardations, so slowing down in the way we think and move, or psychomotor agitation, which is speeding up, being jittery, things like that. And then the most feared complication of depression, or the most immediate complication, is that sometimes people feel bad enough that they attempt suicide. There is something about the syndrome of depression itself that makes people think more about death. So it's not always suicidal thoughts that I want to die or I'd be better off dead. Sometimes it's a tendency to think more about the deaths of people who are close to you, or to think a lot more about deaths that have occurred in the past, or what am I going to do when the people around me die, or what is my spouse or my friend going to do when I die? And those thoughts come to mind a lot more than they do typically. One of the problems we have with recognizing depression is that there are symptoms in degenerative diseases that can look like the symptoms we see in depression. So just as a couple of examples, in Alzheimer's disease, for example, apathy is very, very common. We'll talk about what apathy is in a few minutes. Apathy is very common, and that can look like depression. Sometimes Alzheimer's disease can interfere with appetite, can reduce appetite, or can increase appetite. And in fact, the medications we give for Alzheimer's disease have the potential to reduce appetite as well. So sometimes it's hard for us to tell, is this low appetite because of Alzheimer's disease or the medication, or is it because there actually is depression there? Irritability is common in Alzheimer's disease, and we also see that in depression as part of the psychomotor agitation. And difficulty with concentration, of course, can occur because there are problems with memory. But concentration can be directly affected in Alzheimer's disease too, and that can make it hard to know whether what we're looking at is depression. And similar things in Parkinson's disease, that slowing down that we see of thinking and movement that occurs in depression. Well, slowness of movement in particular, but also of thinking, very common in Parkinson's disease. In fact, slowing down of movement is one of the core features of Parkinson's disease. And then with Parkinson's disease, where people are aware that this is happening to them, it is a natural reaction to maybe have some sadness or regret about that. How do we go about separating that out from the possibility that the individual is having depression? And the way that we do that is really based on finding other symptoms that can't really be explained by the primary disease process, the Alzheimer's or Parkinson's disease. Other than simply feeling bad, right? Depression, of course, by the description you can tell that people with depression do not feel good. In addition, depression has several complications that it can cause in the illnesses in which it occurs. So in Alzheimer's disease, cognition in people who have depression is worse in people, cognition is worse in people who have depression at the same stage of disease as an individual who does not have depression. Depression also makes the cognition get worse faster than it would otherwise. In Parkinson's disease, even though it's hard to know exactly why this occurs, people with Parkinson's disease who have depression actually are less mobile and have more rigidity and more tremor than people who don't have depression. And in stroke disease, people who have depression around the time of the stroke, when you look at them 4 months later, they will tend to be less independent. They'll require more help for more activities than an individual who did not have depression at the time of the stroke. So there's some general way in which depression makes the brain not work as well, and we see that manifest itself across these different diseases. The symptoms of depression can increase caregiver distress. I mean, if you can imagine the difference between 3 times a day is typically how often people eat, and having to sort of beg someone to eat because their appetite is reduced with depression, versus just being able to sit down and have a meal. That one symptom by itself can make a big difference in the relationship between the caregiver and the patient. And you can think of lots of other ways in which caregiver stress might be increased by depression symptoms. Insomnia is another one. If somebody is in a home where there's cognitive impairment and that individual isn't sleeping and wandering at night because of depression, that has a huge impact on what the caregiver needs to do at night, which may involve them becoming sleep deprived and various other things, having to maybe even restrain the patient to keep them from wandering to somewhere dangerous. And it seems that there are higher death rates in a variety of diseases. So not just brain disease, but also cardiac disease, pulmonary disease, diabetes. In all of these, depression seems to increase the mortality rate. So it's not just that depression feels bad and decreases quality of life. It does seem to have an effect on disease outcome. So I mentioned before that we don't think of depression anymore as being just a response to the fact that you have a disease. And there are a few ways that we can tell that this is the case. So one is that people with the same disease, the severity of the disease does not predict the likelihood that they will be depressed. So people with mild Parkinson's disease have depression at about the same rate as people with moderate and severe disease, which indicates that it's not just the person responding to their level of disability. It seems to be related to the disease itself and not the severity or the impact of the disease on the person's life. And we know also that people who don't have insight into their illness, so someone who comes in who has not yet been diagnosed with Parkinson's disease, at the time of presentation, about 30% of people with Parkinson's disease have depression. So this is before they know they have Parkinson's disease, therefore we know they can't be reacting to it. Another good model is Alzheimer's disease, where a lot of individuals they're not even aware that they have any illness, that they have a memory problem at all, and yet they will get depression at the same rate as people who are aware or people who have Parkinson's disease or something else. And we also know that even at the same level of disability, people who have neurologic disease as the cause of that disability have higher rates of depression. So there's something about the nervous system being involved, and that's why we think it's a direct effect of the disease. Furthermore, in people who have different kinds of neurologic diseases, so someone who has had a stroke or multiple sclerosis that leaves them wheelchair bound, if you compare that individual to someone who has had a spinal cord injury that leaves them wheelchair bound, people with multiple sclerosis will have much higher rates. So brain disease tends to cause higher rates of depression than disease at other points in the nervous system, which again sort of points out that this is an effect of the disease on the brain itself and not just the reaction of an individual to having a disease or to having disability. We hear a lot about chemical imbalance when we talk about depression, and to some extent that's probably true, that there is some change in the brain chemistry. But we don't know actually whether chemical imbalance starts depression or whether the chemical imbalance is something that's a result of the depression being there. In other words, we know that people who have depression, we can look at their brain scans and we can see differences in the way that their brain communicates between its different parts, in the neurochemicals that it puts out, but what we don't know is whether that started the process or whether it's a result of the process, right? Because if you get somebody who has depression at that time, you don't know which came first, whether it was the depression or the change that you see in the chemistry. So we use the term chemical imbalance, and chemical imbalance in the brain is associated with depression, but we don't actually know whether that's the cause of depression. But we know that it's related because we know that medicines that affect these neurochemicals have an effect on depression. And we know from animal studies that we can get depression-like symptoms, although it's hard to know what depression looks like in a mouse exactly. We can get depression-like symptoms from altering these chemicals. People with genetic changes in some of these chemicals will also have higher rates of depression. So people with changes in the serotonin receptor or in the chemicals that break down dopamine, those people will get depression at different rates from people without those genetic changes. So we know they're associated, but be careful about saying that, that depression is caused by a chemical imbalance. In neurologic disease, we figure that depression probably has something to do with the loss of cells, with the death of cells. We have about 60 to 80 billion nerve cells in the brain. About 50,000 of those, very small proportion, produce dopamine. A similar proportion that produce serotonin and norepinephrine. So we're having these massive cell losses through the brain, but it only takes a little bit of a loss in one of these areas to change the chemical balance of the brain. And so we know from studies of brains of people with Alzheimer's, brains of people with Parkinson's disease, that those specific cells that produce the chemicals are affected and often affected very early in the disease. So we think that must have something to do with it. The brain isn't working right in brain disease. So the way that the brain is communicating between different parts of its cells changes, and that may be a reason that depression occurs. And then also there's a relationship between brain injury and brain repair and depression. And we know that if there is a brain disorder, that the likelihood of the brain to recover from an injury from any other cause is lower, because the brain's not working well, it's not working at its top efficiency, and therefore if it gets injured in some way, its ability to bounce back from that is lower. So I said that we're pretty bad at picking up on depression. There are a few ways in which we can increase the likelihood that we'll diagnose depression correctly. So first is to recognize how common it is, right? This is something that is a part of these diseases, so it's something we should ask about, just like we ask about memory problems or trouble with getting dressed in someone who has Alzheimer's disease. We should also check on depression symptoms like trouble with sleep, ask how the appetite is doing, how much activity the person is participating in, how hard is it to get them to do things. And those will give you some clues as to whether depression might be present. It's important to get as much information as possible. So the patient, of course, is critical in finding out whether depression might be there, but sometimes the patient will not have all the information that we need. So we have to ask caregivers and people who are close to the patient. We have to trust our own eyes. Someone who's sitting there and telling you that they're not depressed but crying. I mean, this actually happened to me this morning. I was talking to a woman who I asked her whether she thought depression could be a problem. She bursts out crying and says no. So I said, fine, and we moved on. No. So I explored then the symptoms of depression. It turned out she had several of them. Just like I was referring to before, she didn't know what depression really means. So when she found out that, oh, that's why I'm not sleeping well, and that's why I feel unmotivated, I think by the time she left, she was ready to say that she probably did have depression. And a lot of you have some familiarity with the tablets that we have you fill out information on at the beginning of appointments. So part of that is a rating scale of depression symptoms. Again, that doesn't tell the whole story, but it supplements the information that we get from the patient and from the caregiver, and also helps us. We may not remember to ask how good someone's energy is, but that can alert us to the fact that maybe we should explore the question of energy a little bit more. With the first question with depression treatment is whether to treat, because just like any other kind of medication or treatment, there's the potential benefit and then there's a potential burden to it. But generally we lean towards treating, and that's because generally the medicines are pretty safe. They're not going to cause any injury to an individual. Some target symptoms we particularly want to go after because of the implications for everything else in the person's life. So for example, if someone's not sleeping well, the number of different things that can affect is huge. I mean, I'm kind of notorious for being irritable if I don't get my full 8 hours of sleep, well, 10, well, maybe 12. If I don't get all the sleep I need, And that can happen also to people who have Parkinson's disease or Alzheimer's disease. Sleep also affects how well we think, right? So in a disease where memory or thinking is a problem, you want to at least make sure that you can get as much sleep as the individual needs, at least as a minimum, to reduce another impact on their brain function. It's important, of course, that we make sure that, to the extent we can, that appetite is stable, because we don't want people losing lots of weight, because we don't want people eating too much and potentially causing complications with their diabetes or high blood pressure. And then agitation can really get in the way of the patient-caregiver relationship, and it can also impact these other things. Somebody who can't sit still is not going to sit still for a meal, going to have weight loss, etc. Somebody who's agitated may not be able to sleep. Treatment is generally safe, but it is a slow process. The amount of time that is thought to give an antidepressant its full trial is at least 8 weeks and probably 12 weeks, and maybe even longer in neurologic diseases. So it does take time to see effects from these medicines. This is not like cough medicine or pain medicine where you take it and you feel different at that moment. It requires brain changes to occur that take time before you'll see the effects from depression or the effects of an antidepressant. And the response rates aren't what we would like. We can pretty much within a week find almost anybody a pain medicine that if we give it at a high enough dose is going to take the pain away. With depression, like I mentioned before, there's some people who we can't see a really good response with anything. That's the minority of people, but there are times when we just cannot get depression lifted. The other factor is that depression depends on a lot of other issues, right? So all of us, our mood depends on a lot of what's going on around us. And if what's going on around us is not conducive to having a good mood, then even having an antidepressant on board may not be enough to clear the depression. And then finally, there's the fact that especially in neurologic diseases, we're dealing with brains that are different. And those brains usually were not tested when these antidepressants were developed and released to the market. In fact, almost all antidepressant studies require that an individual not have neurologic disease before they enter the study, because we know that the response can be different. So when you hear, Prozac works for depression, you have to remember the context. The context is in, 25 to 45-year-old individuals who have no history of brain disease, who have no history of cognitive problems, et cetera. And we're then applying these medicines because we don't really have any choice. We apply them to people who have all of these things that would have excluded them from the trial. So the response rate is not what we would like, and it's probably because the medicines weren't tested in the types of individuals that, at least here at the Ruvo Center, that we're using them in. It's important to ask a few questions or to think about a few things with treatment. Some of the antidepressant medicines can make it a little bit harder for the brain to work. Not most of them. Most of them are pretty benign in terms of cognition, but some of them can interfere with thinking and memory. Some of them cause drowsiness. Some can cause confusion. We know that in general, even in people without brain disorders, that you're more likely to have a side effect if you're older. The diseases that I see here, Alzheimer's disease, vascular dementia, Parkinson's disease, those tend to happen in people who are over the age of 55. And so already they're starting off from a point, simply by virtue of age, where they're more likely to have side effects. And then in general, the older you are, the more medications that you're on, because a lot of these chronic diseases, we see the effects as people get older, and there's more of a risk of medication interactions. So that's another thing to be careful about. So if an antidepressant is being proposed, those are some questions that you should consider. Are there any negative things it might do to my brain or the rest of my body? How does it interact, or does it interact with my other medications? So the failure rate can be high. And the first thing, it's very important that your provider know that the medicine is not working. We don't have any inherent way of sort of looking at someone and telling whether their overall depression symptoms have gotten better. The only way we know is if the patient or a caregiver tells us that, no, what you tried is not working. Any reasonable doctor shouldn't be offended by that. You know, if it didn't work, and you try something else. But we're not good at asking about depression in the first place. I can guarantee you that most of us are not very good at asking about what the results were of the medicine that we tried for depression. There's a presumption that we started something, and if it doesn't work, you'll tell us. But I think that's not the way people are. I think people generally will respond to the questions that they're asked, and if a question doesn't come up, it'll be perceived as maybe not being that important or not of interest to the person who's asking the question. So if something has been tried, and this is true not just for depression, but for any other symptom, if something was tried and there was an expectation about what it would do and that expectation isn't met, then the provider needs to know that. There may not be anything that can be done about it, but there's certainly not going to be anything done about it if they don't know. Some of the things that commonly get in the way of medicines working: not long enough treatment. That's the most common one that I see, that people treat for 3 to 4 weeks, they don't see an improvement, so they switch to another medicine. Remember that these medicines usually have very wide dosing ranges, so the dose that you start on, very rarely is that the typical treatment dose. Most of the time, the treatment dose is somewhere considerably higher than the starting dose. Not always, and newer medicines, the starting dose tends to be closer to the treatment dose, but that's another thing to keep in mind, that maybe the medicine there just wasn't enough of it. You have to make sure that the individual is keeping up with the treatment. I saw someone yesterday who came in and we went through talking about, you know, how his mood was doing and so forth, and didn't seem that there was any impact from the changes he made last time. And then I talked with his wife separately, and she said, oh, he hasn't done any of those things. So you have to make sure, you have to ask that question, because again, people may not spontaneously report, oh, I did exactly the opposite of what you told me. So you do have to sometimes ask the question, did you do what I told you, if you're the provider, or if you're the caregiver and the patient is managing their own medications, specifically ask them, did you make this change that the doctor talked about? So the ways you can go if there's a treatment failure: you can switch to a different medicine, you can add other medications, or you can add other medicines in general for the depression, or you can add medicines to target specific symptoms. So if someone's not sleeping well and they come back and their mood's much better, but they're still not sleeping well, then it may be appropriate to add a medicine specifically for the sleep or for appetite or whatever isolated symptom doesn't seem to have responded to the medication. And then think about whether what you're looking at is actually depression. And most often, when the diagnosis is wrong, it turns out to be apathy. So apathy is, similarly to depression, very common in neurodegenerative disorders. This is a lack of interest, lack of concern, lack of impact on the individual with apathy by the things and the people that are going on around them. It can be mistaken for depression because individuals with apathy will generally be less active, they may not look as happy, and it can be caused by depression. So depression can cause apathy, and it makes it hard to distinguish between the two. So what you will see in apathy is really a decrease in sort of direction and motivation in the individual. There will be less directed behavior. They will tend not to start activities. If they start activities, you'll often have to keep them stimulated in some way to keep them doing it. You can't sort of say, hey, do this for the next 2 hours, walk away and expect that it will continue for the next 2 hours. And very often there's no specific explanation. And very often the intention is, if you say, will you do this for the next couple hours? The apathetic person will say, oh yeah, sure. And you come back in 5 minutes and they're sitting on the couch. Well, what happened? I don't know. And the problem is that there isn't the internal drive to get things done or to finish them. The same thing happens with thoughts and emotions. So there isn't a lot of spontaneous emotion, and the reaction to things that are going on in the environment around the apathetic individual is much more muted than you would expect. Even so, these people are not depressed. In fact, my most apathetic or second most apathetic patient says this is the happiest time of her life. And her family agrees that she looks completely happy and content, but they really can't get her to do anything. Hey, you want to go out, Mom? No, I'll just keep doing this. Well, what are you doing? Well, nothing. Do you want us to change the TV channel? No, that's okay. I'm watching this. What's on? You know, whatever's on. They're just really unconcerned about what's going on around them. It can be easily confused with depression. So when you see this lack of initiative, how can you really tell if it's maybe the reduction in energy that depression causes or the decreased interest that you see in depression? When they stop doing a task, could it be because they ran out of energy? They get the easy fatigue like depressed people, or is it because they can't concentrate on the task because they're depressed? The lack of caring could also be from being sad or from having less interest, and the lack of reaction can be part of that slowness of thinking. Really, the way that you can tell is by getting a report on their overall mood state. You ask the person whether they feel pretty content or pretty happy, or whether they feel like things aren't quite right. It may not be sadness, it may not be despair, but usually people who are depressed will not feel good in general. And they may not describe it as being depressed or sad, but unlike the apathetic person, they also probably won't say, no, I feel pretty good. I'm pretty happy with the way life is and the way that I feel. And then we also usually don't see in apathy problems with sleep. We usually don't hear them ruminating over guilt and worthlessness. We don't hear the preoccupation with death. I put an asterisk by the change in appetite because people who are apathetic can sometimes be so apathetic that they don't even pursue food, that they'll sit there. If food is brought, they'll eat it, but they won't say, I'm hungry, or get up and look for food, again, because that internal drive is just not there. But it's not a change in appetite, because if the food's in front of them, they'll eat it all. Just, they're not going to put out the energy to actually think of what to make or get up and do it. We don't have any really good treatments for apathy. Not that we have any really good treatments for anything in these diseases, but apathy in particular, we really lack treatments for. The Alzheimer medicines like Aricept and Exelon and Razodine, those medicines in some studies of cognition seem to show, when apathy was measured, that they may have reduced apathy some. And I've had some individuals, some patients, who did seem to get much less apathetic when these medicines were used. But I would say that's not the typical case, that when they do help with apathy, it's in the minority of people. Antidepressants have been looked at because, like I mentioned, the symptoms are pretty similar. If antidepressants help to increase someone's interest and energy, might they help the apathetic person in increasing their interest and energy? And it turns out they really don't seem to. So just about every study that's been done of antidepressants in apathy turned out negative. And that's also useful information for showing us that the two really are different. Also important information for telling us why it's important to recognize the difference between the two, because you could spend 10 years trying to treat apathy with antidepressants and getting frustrated every time another one doesn't work. Or if you recognize at the beginning that antidepressants usually do not fix this problem, I think it's much easier for the caregiver and the patient and perhaps the provider, the medical provider, to cope with the fact that, we're trying something, we don't expect it to work, but we think we should try. Stimulants, so medicines kind of like Ritalin or Adderall that you may have heard of, that are used with people with attention deficit disorder, these seem to have the best response. When I say best, though, we're talking about somewhere between a quarter and a third of people who are started on a stimulant responding. And they have their own problems. So stimulants can increase heart rate, they can lower appetite, they can impair sleep. And so we use them with caution. They're also difficult to use because a lot of insurance companies will not cover them, and they can still be quite expensive. And then because they're controlled substances, you can only get a prescription for 1 month at a time. You can't do refills on it. You can't get it by mail by just calling it in. So it makes them very hard to use, and often, because 3/4 of people aren't going to respond, more trouble than they're worth. But in some situations, the apathy interferes with activities that would happen if the person weren't so apathetic. And so we do try to use them. So depression and apathy, both are very common, but it's important to recognize they're not the same, even though they can look the same superficially. They seem to have different origins. They're caused by different things. The treatment is different, and the likelihood of response to treatment is also different, and the consequences are different. So with depression, we talked about the increased mortality, the increased rate of cognitive progression, and so forth. We don't really see that with apathy per se. It seems to be just a symptom of the disease that tracks along with the disease without necessarily making any element of the disease worse. But even though we don't have great treatments for them, we do try to treat them, and it's important that we recognize when they're there so that we at least have the option to think about whether we should treat or not and what that treatment should be. So I'm just going to stop because we only have a little time left for questions because somebody was late. Are there any questions? Oh, you had your hand up like 5 minutes ago. Good.
So if there's no intervention with depression, will it continue to get worse and worse? So perhaps the medicines or the treatments are doing good, but we're just staying at a even keel?
That's a good question. If depression is not treated, will it get worse and worse? There is usually depression doesn't start off at the same severity as sort of the worst it gets to. But we don't usually think of it as being progressive, like, say, Alzheimer's disease or something like that. There is some point at which that's sort of the worst that someone's depression gets. Now, that worst can be pretty awful. I mean, people can be paralyzed in bed all day, not eating, not talking because they are so depressed. But in general, you won't sort of see depression evolve over years. And so when we treat with antidepressant medications, yes, sometimes we see that there's a partial effect. The person is still depressed, but they're better than they would have been without the antidepressant. But our expectation or our target should be to get rid of the symptoms. Our target should be remission. There's a lot of question about whether remission is as achievable in people with neurologic diseases as we see in the people in whom these drugs are tested. But because we don't have evidence to suggest otherwise, the target should be that you get rid of the symptoms, even when it's a depression within a neurologic disease. Does that answer the question you're asking?
I was just thinking perhaps you're shortchanging yourself, though, by not giving yourself some credit for the fact that
I need you to talk to my wife because she thinks I'm arrogant and overblown. Will you sign a document?
Piggybacking on that gentleman's question, is there a physiological or psychological reason why many depressed people do not want to look for help?
Is there a physiologic or psychological reason why many depressed people do not want to look for help? There must be. I don't know if we know for sure, but the reduction in energy, the feelings of worthlessness, why would you expend energy on yourself if you don't feel that you're worth very much? I imagine that those must play some role. And then also sometimes lack of insight, the lack of awareness that this, first of all, that it's present, secondly, that it's a medical problem, and thirdly, that it can actually be treated and helped. And sometimes people with depression do become frankly psychotic, where they feel they deserve what is happening to them in terms of the depression. Now that's unusual, clearly not the majority, but I think a gentleman last week said to me, you know how some people, or he was talking about himself, he said, you know, if there was a needle with some medicine in it right there that would cure the depression, I wouldn't even get up and get it because I don't have the energy or the desire to do anything. And the reason he brought that up was he said, oh, music usually makes me feel better. So I said, well, do you play music? And he said, no, my wife doesn't like me to play the music. And she said, I'm at work 8 hours a day. He's at home by himself. There's no reason to avoid the music because of me. And then he went on to say, you know, if there was something there that would cure the depression, I wouldn't even be able to get up and get it. Let me just check on questions remotely first to give a turn.
Yeah, we have a couple questions. One wants to know if a person's been on an antidepressant for a long time, can it become ineffective, or if they increased it, could it help more?
I don't have to repeat that one, right? Okay. So there are times when people are on an antidepressant for a long time and then the depression starts to emerge again. Whether that's the antidepressant becoming ineffective or whether it's a change in the disease, not sure. Some people do respond to just a dose increase of the same medication. But we don't know what is behind that actually. Why it is that sometimes when people are on an antidepressant and doing well for a long period of time, that sometimes the depression will pop back out.
And one other question.
Oh, just hog it all.
Is menopause associated with becoming depressed?
Is menopause associated with becoming depressed? Well, when I was a boy in psychiatry, we used to say that yes, that higher rates of depression occurred around menopause. I don't know, frankly, whether that's still the case because it's not an area that I study that much. And this is a specific area within psychiatry, the effect of hormones, particularly sex hormones, on mood and on cognition. So I'd be hesitant to say yes or no to that, but it's definitely not an unreasonable question and something that people are actively looking into. I would guess that with any significant shift in the hormone status, that there could be a higher risk of depression.
Can depression go all the way back to childhood and you can trace it back to an incident, or could a person have it from more or less birth or early age? Can
depression go all the way back to childhood? So yeah, there are people who have not felt right in terms of their mood their whole lives. It is very hard, you know, if I see someone who's 40 years old and tells me I've had depression all my life, to know if what they're talking about that they're experiencing right at this point is the same as what they were experiencing when they were 12. But there are clearly people whose mood has not felt right to them through their whole lives. And there are biological changes that are associated with depression that seem to be more common in people who have had difficult childhoods, verbal or physical abuse, or unusual circumstances. But that's, often you don't find any history of any of that in someone who nevertheless feels that their mood just has never been right.
So a person taking antidepressants, can that lead to apathy if, along with the dementia? Which would be causing the apathy, dementia or the antidepressants?
So the question is whether antidepressants, and specifically in this case in someone with dementia, could the antidepressant itself cause apathy? There is a syndrome with some of the antidepressants, particularly the SSRIs, the serotonin selective antidepressants. There is a syndrome where people feel kind of flattened out. And I've seen it in patients too. They come in and they say, no, I'm not crying as much anymore, but I'm really not feeling much of anything as much anymore. So yeah, there's an apathy-like syndrome that can be caused by the antidepressants, and there's no reason to think that if if we know that this happens in people without brain disease, I'm sure it happens a lot in people with brain disease. And people with brain disease are probably more susceptible. But as with all of these things, determining cause and effect and what would happen if you remove the antidepressant is very difficult.
Can you, depression and apathy, can they occur at the same time?
Can depression and apathy occur at the same time? Absolutely. If they do occur at the same time, usually you start off with the assumption that the individual has depression and apathy is coming out of that because of the lack of energy and so forth, and you try and treat the depression. And the way you know if they were actually separate problems is if you get a substantial improvement in the depression symptoms that you can separate from the apathy. So that would be if the mood gets better, if they start saying, yeah, I feel pretty good, and if sleep was a problem and now it's better, appetite is now better, but they are still disinterested and unconcerned, then you would say, okay, it looks like there's apathy that's separate from depression here. Always keeping in mind what was brought up a little bit earlier, that the medicines sometimes can suppress that motivation. That suppression is not usually as intense as what you see with sort of primary apathy or apathy from a degenerative process.
Is there any correlation between depression and low levels of vitamin D?
Is there a correlation between depression and low levels of vitamin D? I'm trying to think if I know any specific data on that. I can't imagine it hasn't been studied, but I can't think of any specific studies that have demonstrated that. Sorry, yes, actually, I'm sorry. There is a study that associated vitamin D deficiency and depression, but it was a cross-sectional study. So it took a bunch of people with and without depression, took their vitamin D levels. The people who were depressed were more likely to have low levels of vitamin D, but it's difficult to tell if that was a cause or effect and whether it was a biological effect or a lifestyle effect. One of the ways that we generate vitamin D is going out in the sunlight, which happens a lot less with people who are depressed. So I know that stimulated some discussion and probably some studies on the topic, but I don't know what the results of those were.
Are there any natural methods that you could recommend for us to talk to people with depression?
Natural methods to talk to people with.
Well, like I was thinking, like I read a study about the vitamin D deficiency, and I was thinking, like, is there any when I say natural, like vitamins or minerals or changes in their diet that could help people with dementia and depression?
Oh, so natural, so non-prescription medication treatments for depression and dementia?
Yes.
Yeah, so exercise clearly is beneficial for both depression and dementia. I don't know if it has, if it's a synergistic effect in people with both, but we know that at least separately, exercise reduces rates of cognitive impairment, and in people who have mild dementia can actually improve their cognition. And exercise also helps with depression symptoms. Vitamin E has been studied for both dementia and depression. High doses of vitamin E reduce the rate of cognitive impairment, or at least of going from mild to moderate cognitive impairment. The studies of vitamin E in depression have not panned out to really demonstrate anything significant. So I think those are the only things that I can think of offhand where there's been a benefit clearly shown in both, or clearly a benefit in one and not in the other. There are lots of natural things that help with depression and some natural things that help with dementia, but most of those haven't been studied in both syndromes. Okay, you'll go first.
How do you make the decision about whether or not to treat the apathetic person that does not have depression? In the example of the apathetic person that's really happy, I would assume it's not worth trying to treat that. But I guess I just don't really understand what kind of major issues arise from apathy that would say, okay, we really need to treat this.
Okay, great question.
Especially in the person that's over, 60 years old,
Yep.
or, that's possibly not in the workforce, or doesn't really need to complete a project,
Yeah.
or.
So the question was, what would drive you to treat someone who's apathetic? If apathetic people generally feel pretty content and satisfied with their existence, then why would you treat it? So probably the biggest area in which I treat that is where the only thing that I can do for their cognitive impairment is increasing their level of activity. So people with vascular dementia, for example, where we don't actually have medicines that are approved for the treatment of vascular dementia, where we don't have studies here in which people with vascular dementia can participate, and where we know that the dementia, as well as most of these individuals, have either diabetes or hypertension. We know that medically exercise is important for them for continuing their life the way that they like it. Those are people in whom I might be more aggressive about treating apathy. But we always have to keep in mind that we're not treating the provider and we're not treating the caregiver, we're treating the patient. And so when we talk about the potential benefits of treatment versus the burden, it always has to be in respect to the patient that we're talking about. And so if I would say that if I were to estimate the percentage of people with apathy that I actually treat aggressively with something more than maybe 1 or 2 attempts at an SSRI, probably 20% or fewer, because of precisely that they're usually okay with it. Other question?
Can depression be genetic?
Can depression be genetic? There are definitely there are genes that predispose toward depression, and then we know that depression and mood disorders run in families in ways that we can't tell if it's a particular gene or collection of genes or way of managing the world that someone might have been taught by their parents or by watching their parents. But we know for sure depression runs in families. We know for sure there are genes that cause that to happen.
Well, ladies and gentlemen, join me in thanking Dr.
Thank you.